I'm so pleased to introduce to you Dr. Nancy Rudner. As you all know, Florida, as we've been publicizing, it has some of the most outdated set of nurse practitioner regulations, limiting what the nurse practitioner can do and placing more of a burden on the physicians. Dr. Nancy Rudner, co-author of the national study ranking state NP regulations. Sadly, Florida got an F, and you can ask how Florida got an F, and it isn't just because Florida starts with an F. A nurse messenger for the AARP campaign to champion nursing. She will discuss the role and potential of these nurse practitioners. Dr. Rudner, a family nurse practitioner and nurse coach, holds a doctorate in health policy from the University of Michigan. She is president of Health Action Biz, a nurse coaching service to help employees and others set and achieve their health goals. Please, let's give a warm welcome to Dr. Nancy Rudner.
I want to start out by asking you all, is anyone here a nurse? Got 2 nurses at the table. Good. All right. What are some of the problems in healthcare? You could probably think of a few, right? Anyone? Bureaucracy. Well, and that I don't think nursing can address, but that's all right. But what's some of the challenges, especially going forward? What? The cost of care, the cost of providing care. Other issues? What? Well, for you all, getting in to see the doctor, or as we call them, the healthcare provider, because there are many different roles. And that's part of why I'm going to talk to you about nursing. Now, I wear a couple of different hats. The future of nursing is a study done by the Institute of Medicine, which is a policy entity in Washington, D.C., part of the National Institute of Medicine. And they did a study called The Future of Nursing. And you can go to futureofnursing.org online to see the whole report. And I'll talk about that in a little bit. And then AARP, you see the logo on the bottom, has enacted the campaign for action to implement the recommendations of that report. And that's part of what I'm going to talk about, and I'm going to talk about Florida specific and some of the challenges in Florida that we have in unleashing the potential of nurses and nurse practitioners. Well, some of the challenges, which one of you did mention high costs, that's good. It is fragmented and it's chopped up. And you can see that, and that's one of the goals of the accountable care organizations and the patient-centered medical home is to cut down on some of that chopped upness, have more care coordination. But if you've been a patient or have helped someone getting care, you can see how complicated it all is and all the different pieces. So we have this very fragmented system. Some of you who are setting up IT systems, that's supposed to address that too. It's a wonderful step forward. We have healthcare disparities. We have outcomes are significantly different for African Americans, Hispanics, and non-Hispanic whites when you look at the data. So when you look at why are those differences. And that's part of our healthcare system or non-system. We have an aging and sicker population, right? The baby boomers. Any of you here might be in that group, right? And if you are, you've probably been thinking about that R word somewhere, retirement at some point, right? But as you're aging, you're noticing some health problems start popping up. So we got this big baby boomers coming forward. And we also have a primary care shortage. A lot of the information that was around starting the 3 new medical schools in Florida was all about how we're going to have this primary care shortage. But lo and behold, a lot of the graduates don't want to do primary care, right? And that gets us back to high costs because primary care is the less expensive care. And those of you who have primary care practices know you don't get reimbursed the same way that a cardiologist gets reimbursed for an hour of care. And by the way, interrupt me with questions at any point, okay? So we're going to need more primary care, partly because the aging population, right? Then we have this whole issue of obesity. Now, this weekend at the beach, look around, right? And if you don't go to the beach, go to Walmart or Costco, and you will see we have an issue, right? And what that obesity is going to mean, right? It's going to need knee replacements. It's going to mean diabetes, hypertension, high cholesterol, depression. They all go together, right? All that's going to require health care or medical care, depending on your perspective. Right? Then we have health care reform law, the Patient Protection Affordable Care Act. 37 million more people will have access to care. Those are the folks that have been driving by your offices, but they don't have an insurance card. They're not coming in. But then when they're sick, they're showing up at the ER. So we've been paying for their care for when they're sick, right? But they haven't been coming into primary care. And one thing I want to point out about, think about hypertension. Easily controlled with a pill you can get for $4 a month from Walmart, but you can't get that pill until you got in to see a primary care provider. You don't have insurance, you don't go in to see the primary care provider, you don't get that medication, you have a stroke, you go to the ER, you get hospitalized, you go into a nursing home, you're medically indigent, we pay for care at that end. So one of the changes with healthcare reform law is a much stronger emphasis on prevention and primary care. Get people that care to prevent the high-cost care we're already paying for. But here we have a challenge. Only 10% of medical students want to go into primary care. Right? And it's like Willie Sutton in the bank. So anyone remember what Willie Sutton had said? He was a bank robber. He said, Willie, why do you keep robbing banks? He says, because that's where the money is. So only 10% going into primary care because that's not where the money is. Now, the Institute of Medicine report said that in order to have high-quality, patient-centered care for all, it's going to require a transformation of healthcare delivery system. And you've had various speakers here talk about the healthcare delivery system changes, transformation, accountable care organizations, patient-centered medical care. The health plans you're involved with, how you're talking about different payments, pay for performance, pay for quality. All these changes are afoot. We don't quite know where all those changes are going, right? But we know that there's a lot of change that will happen, and we know we have to have change. Healthcare has become the biggest chunk of our expenditures as a nation. It makes it difficult for us to compete nationally, right? Something has to change. But this Institute of Medicine report on the future of nursing is one of the most viewed online reports in the Institute of Medicine, and you can read it at iom.edu, or you can just Google Future of Nursing. Now, let's back up a little bit and talk about who are America's nurses. There's 3 million nurses or RNs in the United States. 45% started with an associate's degree. In Florida, it's higher than that. The community colleges have done a wonderful job of training and educating nurses and starting nurses, but many nurses also go on and get a bachelor's degree because ultimately that's what's required. But what we found is in the United States, college nursing programs turned away more than 75,000 qualified applicants. They could have gotten in, but the capacity of the school is limited by short funding for the school, shortage of teachers, shortage of clinical sites, shortage of preceptors. Now, there's been a growth industry of for-profit nursing schools as well, trying to respond to some of the demand for that. But that's also financially out of reach for many potential students. And now, 5 years ago, there was a lot of talk about the nursing shortage. Then we had the recession. And the nursing shortage sort of went away because partly for a lot of nurses, there are other wage earners in the home lost their jobs, so they went back to work. Or they didn't retire. But it's coming. Because as you see in the bottom bullet, the average age of the nurse is 47 years old. So retirement in 10 years, 15 years is coming. The other part is as hospitals have shifted to 12-hour shifts, when you're over 50 or 55, being on your feet for 12 hours just isn't as easy as it was when you're 25. So there's higher demands, especially for in-hospital nursing. But we also expected nursing positions to increase by 22%. Now, if you the other issue that we have is racial and ethnic minorities make up at least 30% of the United States. It's expected to become 50% in the next few years, but only 15% of the nursing workforce. So to have a population of nurses that reflects the population served, and that really to help all the nursing profession really understand the diversity of patients, we need to have a diverse workforce. The other part is, in the past, it's been less than 10% of nurses are men, and they don't even call them nurses; they call them male nurses, like a different species, right? Right? That's changing, right? Now, in my nursing program, a third of the students were men, and it doesn't make a very different flavor. We used to call it vitamin M. No, just the pheromones of having men around just changes the dynamics, right? And I see some of the men nodding. I see some of the women nodding. We won't even go there. All right. But there's all these studies that showed it really matters that having nurses and having well-educated nurses. And when with the nursing shortage and the increased workload, now remember the other big change in the past 20 years is people in the hospital are sicker. You get sent home a lot quicker. So that means the people who are left in the hospital are the sick ones that take a lot of care. So it's basically what would be called a work speed up. Work has gotten very intense. And then there's all this technology, which some of you help get in place, but it's a different demand and a different skill set. But what we found is when you have a higher ratio of nurses to patients in a hospital, you get fewer hospital-related deaths and shorter lengths of stay. And then patients with common surgeries in hospitals with the worst nursing staffing levels, in other words, more patients per nurse, have a 31% increased chance of dying. So basically, your life depends on how many nurses they have there. And then surgical patients had a substantial survival advantage. What a way of saying they live as opposed to die, right? If treated in hospitals with higher proportions of BSN, bachelor's prepared nurses, and master's prepared nurses. Every 10% increase in the proportion of BSN nurses in hospitals had a 4% decrease in death. So education matters. Education makes a difference. Nursing makes a difference. Right? And it makes a vital difference. It's an issue of survival. Now, California nurses organized, and they went out to the community and talked to people, and they gathered stories of how nursing shortage had affected people's lives. And in California, they instituted mandatory ratios in the hospital and nursing homes of how many patients per nurse. And that's controversial, it has pros and cons, but that was one approach to address the issue. If you go to the website, one of the things about healthcare reform law is more transparency in healthcare, more reporting. And hospitals and nursing homes have to report things like the nursing patient staffing ratio. So if you go to healthcare.gov/compare and pull up some of the nursing homes, and it will show you the nursing patient ratios and various other quality measures. And I think there's 44 measures for hospitals, and it might be in there for hospitals as well. It's not, and then if you look there, it also has a tab for physicians or medical offices. But there's not a lot of data in there. But if you look and see what's going on in the others, you can see where this is heading and the different types of quality reporting that we may be getting to in the coming years. All right. Now, what the nurse practitioners say is that we have over 100,000 solutions. We have issues of distribution of where providers are. Rural health has always been an issue where 25% of the population lives, but only 10% of physicians are in the rural areas. And the United States has nearly 400,000 primary care providers. Of those, the majority are physicians, 275,000. But we have 80 to 100,000 nurse practitioners and 20 to 30,000 physician assistants. Physician associates, the practice group in town. All right. But physician assistants, nurse practitioners, they are not substitute physicians. They're a different profession. They have a different set of skills. It's complementary. It provides some similar services, but it's not a substitute. As Loretta Ford is the founder of nurse practitioner, she was the first nurse practitioner. She developed the role. And one thing she says is nurse practitioners don't want to be like doctors. In fact, that whole practice model is not working, and it's shifting. That's an old horse that we don't want to ride. And really, the nurse practitioner is much more originally trained, much more focused on education, prevention, and guidance. It's changed a lot. It's been used in lots of different ways, but it is a separate profession. And currently in Florida, well, nationally, nurses are the only profession that is supervised by another profession. In Florida, we'll talk about the Florida rules in a minute. Now, the AARP campaign to champion nursing has a vision that all Americans will have access to high-quality, patient-centered care in a healthcare system where nurses contribute as essential partners in achieving success. When we look at boards that are governing on healthcare, nurses are underrepresented. That's why the phrase is we want to have more nurses at the table. We do have 2 nurses at the tables here. But nurses have been providing a lot of care, but they haven't been part of the policy dialogue as much. And there is a phrase that we say in policy, is that if you're not at the table, you're on the menu. And we have seen that certainly in Florida politics. Now, AARP, you're all familiar with AARP, right? First you think of old people over 50, right? Well, as I look around, almost all of you qualify. Membership is $5 a year. You get great discounts, okay? It's also an advocate for quality of life for the population over 50, which is not old, but not retired either. That's why they sort of switched to AARP instead of the American Association of Retired Persons. Because who's retiring at 55 or 60 or 65? Anyway, but they're saying this is not an issue just for seniors. This is an issue for everyone. Together we succeed. If we divide and conquer, we will all fail. And so that we really need a high-quality healthcare system that meets the needs of everyone. All right. And the campaign has 3 action pillars. One is advancing education transformation. We have to keep the stream of nurses flowing. We have to improve the quality of nursing education. We need to have easier access for nurses to get a bachelor's degree. So that nurses can go from a CNA to an LPN perhaps, to an RN, to a BSN, and keep going. We want to remove the barriers to practice and care because there's lots of ways that nurses can contribute, but the regulations don't allow it. And I'll talk about some examples of that. And really and develop more nursing leadership and have nurses more engaged in decision-making and policy-making. In some of the practice you've seen, can you think of some of the barriers to fully utilizing nurses? Anything that you've experienced? No? Well, one I often think about when you're you've got it's a busy day in the office. You've got a lot of patients waiting, and you get a call because the patient you have in the hospital is constipated, and the nurse is calling to see if you would write an order for a stool softener. Right? Totally stops the whole flow of primary care. And do you really need to be a physician to decide the person is constipated and needs a stool softener? So we have this bureaucracy that just brings everything to a grinding halt. All right. Now, part of practice is, and this is part of the campaign, the future of nursing, the recommendations for the future of nursing, and the campaign for action, is saying all practitioners should practice to the full extent of their education and training. We call it practicing to the top of their license. And physicians, nurses, and other health professionals should work in a team-based model of care as equals, right? Because they all have different perspectives to bring in. Now, sometimes in office practices, the physician really knows the deep clinical, cellular level part of the process. The front office staff knows the patients and can tell you, and also may know the community, and can tell that team a lot more background information that would help build a circle of care to help that patient be successful. So everybody can contribute for a much more successful approach. And there's been all these studies that showed that, especially in diabetes, for example, a multidisciplinary team working with a patient with diabetes is much more successful than a primary care provider solo. So we want to have models of care that maximize the time that providers can spend within their roles and the responsibilities for patients. And from that is coming a lot of creative models as well as things like group visits, where patients can work together, talk together. It's much more efficient, than educating one person at a time. It's worked well in prenatal care. It's worked well with diabetes care. It will probably work very well with all models of chronic disease. Now let's go back to where this regulation of nurses comes from. The states regulate the professions. It's not regulated federally. It comes from the state's obligation to protect the public safety, and it's based on the premise that consumers don't have all the information to assess provider care, healthcare provider quality. And it's true when you think about when you go and decide whether a doctor is a good doctor, a lot is based on what the office looks like, which is interior decorating, and maybe we have some folks interior decorating here. It makes a big difference, right? How well his phone systems worked so that when you called, you got through or were able to leave a message. We got the phone, folks, right? How well the doctor talked to you, which is interpersonal skills, right? Which the guy probably, you learned everything I learned in kindergarten, right? Everything I need to know I learned in kindergarten. Whether the practitioner talks to you or listens to you or interrupts you and ignores you. That's all personality. What we have a hard time as consumers judging is the quality of care. Right? So one of the things with the healthcare reform law I talked about earlier, we're going to have ways, it's measures and quality measures. Whether you think that measures quality or not, it's a whole other discussion. But there's trying to be more transparency so you know something about the person who you're trusting your health with. But based on the premise that consumers don't know who's a good doctor and who isn't, states regulate it. They license the doctors and nurse practitioners and certified nursing assistants and everyone else. And basically, it's a credentials check. Because the goal is the states to protect the public from unqualified providers by providing and establishing qualification requirements and defining the scope of practice and practice requirements. Okay, so the state determines the Medical Practice Acts, what a physician can do, and the Nurse Practice Acts, and also what all other healthcare providers can do. As a result, we have this very patchwork system of healthcare regulations because each state is a bit different. Now, where did this come from? Let's look at the history of it. The medical profession established itself first. In 1760, think about what the United States was like in 1760, New York City, which then was the center of the universe and still thinks it is, prohibited practice by unlicensed physicians. Because basically in those days anybody could say, I'm a physician. That's when the word quack developed. And you've seen movies where they're selling elixirs. Right, so 1760, they started it. New York City started it. In 1910, the Flexner Report came out, which said, we need more science in healthcare. We need to have more controls over who's a physician, what they're doing, how they're providing care. And that really changed things. From the Flexner Report, we had a total revamping of what constitutes a medical school. And that's when the medical schools really got, as we know it today, got established. So since those laws started around medical care, the other professions that came to healthcare afterwards had to fit around them. So from 1930 to 1950, the state laws defined nursing as independent acts of observation, tasks, recording, and permitted nurses to do as delegated by a physician. Even blood pressure measurement was considered a medical function delegated to the nurse. And in 1970 in Texas, for example, a nurse could not teach a woman self-breast exam. It was considered outside the scope unless delegated by the physician. Well, what this does with this funny patchwork and all these little rules is create a lot of opportunities for legal errors, where things are done and they shouldn't be done because it's not, unless it's specifically delegated. It also makes it very hard for the profession of nursing to practice nursing, because if their professional perspective is overshadowed by not being able to do anything unless it's delegated by a different profession. In 1960, Loretta Ford started the nurse practitioner role. Loretta Ford she started the nurse practitioner role in Colorado. She became the dean of the College of Nursing in Rochester. And then she retired to Wildwood, Florida. So she's been watching the stuff in Florida with a ringside seat. And one of the things she said last week, she was at a convention here in Orlando, was we should have gone for federal qualification of nurse practitioners and had one rule, one set of scope of practice and regulations instead of every state doing it differently, because it's so varied. Since 1960s, there have been many revisions of state nurse practice acts, allowing nurses to do more, allowing nurse practitioners to do more, changing it. And let me go to the next slide. There's lots of studies that have been done that show the quality of care provided by nurse practitioners is equal to or exceeds that of physicians. But that's a funny benchmark. It's really a different profession. But it shows that nurse practitioners permitted to practice to the full extent of education and training provide equal or better care. That lots of studies showed that the outcomes are equivalent. Patient satisfaction, lengths of stay, diabetes control, cholesterol control, fewer C-sections, fewer episiotomies, all these ways that we look at quality of care are pretty good for nurse practitioners. So it's really, the evidence shows there's comparable outcomes. We're not saying it's comparable care, but the end result is comparable. All right. Now this shows some of the access barriers to primary care in different states. The purplish states have no requirements for a collaborative agreement with a physician, and then the dark blue ones require a physician to be involved to diagnose, treat, and prescribe. The problem with that is one is it raises the cost of providing care. That you can have to have some, and now we have limits on how many nurse practitioners can work under one physician. What does that oversight look like in reality? Typically, it's a financial oversight. It means that the nurse practitioner's billable hours go into the pot of money. The nurse gets a salary. The other money comes into the practice. In reality, it doesn't. It means that might mean that the physician is there to answer questions, but typically the physicians don't review all the records. Some places they sign off, but they sit in a room for an hour and sign records. Right? The oversight became much more of a legal question, and it really does not enhance. There's no evidence that enhances the quality of care. One of the things that we need is that we need our regulations and our laws to be based on what the evidence shows, not on politics. But as they say, politics are like sausage. You don't want to watch either one being made. Right? They're not based on facts always. So there we are in Florida, hanging out there with the requiring physician oversight to be able to prescribe, to diagnose, treat, and prescribe. The light blue require physician involvement in order to prescribe only. So, for example, I have a practice of doing, I do workplace health promotion and health coaching. I see a patient, I check they got out of control blood pressure. Right? Because I don't have a supervising physician, because I don't pay a physician to oversee what I do, so I have to keep my scope of practice limited, I have to send that patient to a doctor to get the prescription so they can go to Walmart and pick up the drug that will control their blood pressure. At least I can tell them what they have, that their blood pressure is high. We've come a long way from the 1700s. But the cost of providing care goes up because a physician has to be involved. We call that the doc tax for healthcare. Now, the study that I did with 3 other people, we looked at how the regulations of nurse practitioners affect consumers. We looked at the access to your choice of a provider. How easily can nurse practitioners enter the market to provide care? We found a wide range of things. You had to graduate from an accredited school. That makes sense. There's national accreditation. Once you've graduated from accredited schools, in some states you have to intern with a physician or a dentist or a podiatrist for a year. Now that's a different model of care. Right? In some states, you had to have your certification test. You had to pass the certifications test, which makes sense. There's a national certification, but it wasn't in every state. In some states, a nurse practitioner could provide a model of care in the community with or without a physician. In other states required it. Then we looked at access to tests and services. If you're a nurse practitioner's patient, do you have equal access to tests? Some states, the nurse practitioner cannot order x-rays or cannot order lab work. In Florida, until this last session, nurse practitioners could not order physical therapy. So they had to get a physician to sign the request for physical therapy. That interrupts the whole flow of care, but also the physician is signing something without really having seen the patient. And then we looked separately at access to medications. And Florida and Alabama had the most archaic nurse practitioner regulations for nurse practitioner prescribing. Nurse practitioners in Alabama at the time couldn't prescribe at all. It might have been Georgia. It was Alabama or Georgia. But in Florida, nurse practitioners could not prescribe controlled substances. Now, controlled substances, there's been all this stuff about the pill mills and pain medication. Well, controlled substances also include some cough medicine with codeine. It includes the medications like Adderall for attention deficit disorder. It includes seizure medications. So you got a kid who's been well controlled with his seizures or his ADHD for years. Comes to see the nurse practitioner, can't get the prescription, right? The nurse practitioners have been in practice with a physician. It's got to get the physician to sign. Some practices gave the nurse the beginning of the day or the beginning of the month several pre-signed scripts. Totally illegal. It was a workaround. Totally illegal, very scary, and there have been lawsuits that have happened in Florida. What nurse practitioners are saying is, I want to be responsible for what I prescribe. I want my name on what I prescribe. Having someone co-sign who hasn't seen the patient is not does not ensure any more safety. In the states where nurse practitioners can prescribe fully with everything that's available, there's not been a higher rate of any problems. Now, the prescribing for controlled substances in the pill mills, it is horrible. It's been in the news. It's not our biggest healthcare issue. We should crack down on people who abuse prescribing privileges, whether they're physicians or nurse practitioners or whatever. But limiting nurse practitioners and what they can prescribe actually just hurts the consumer. All right. So Florida's, what we found is you had to have this collaborative agreement, which often means you have to pay a physician. That's the doc tax. We can prescribe medications, but as I talked about, you can't prescribe controlled drugs. But now they changed the rules. Now nurse practitioners can order physical therapy. So the patient goes to physical therapy. Then the physical therapy does a treatment plan. It comes back. The nurse practitioner can't sign it. The physician has to sign it. So really what we have is physicians signing things that they're not reviewing the whole chart. And physical therapy, you really think about it, physical therapists are a separate profession. They know what they're doing. When I get a physical therapy treatment plan, I don't question it. The physical therapist knows what they're going to do. Right? I have never seen a clinician question the physical therapy treatment plan. Right? It's just someone said bureaucracy was one of the problems. Here's a classic example. We could cut out some bureaucracy. Now the Baker Act, that's how when you have someone who's mentally ill, committed for observation, nurse practitioners cannot Baker Act somebody unless they're a psychiatric nurse. So you got someone who comes to your office. They're totally mentally ill. They tell you they want to kill themselves or kill someone else. You have to say, hold on a minute, let me get a doctor in here to get you into the hospital. Right? And there have been cases where the patient left and said, I'm not sticking around. I got a plan. Right? Yeah. And now gun control is a whole other issue, but okay, this does not ensure community safety or patient safety. It's just the bureaucracy that doesn't meet our needs. So when we compiled the scores from all the states, we had we had all these different measures that we looked at, and here's a sampling. Arizona ranked this as the top, where nurse practitioners could practice, they could prescribe what needed. Patients had access to medication. They got an A. So did Washington, Oregon. You'll see in the map next. New York had some limitations on entry into practice, but Florida was down there with Alabama with the F. Yes, Alabama was the really restricted one for prescribing. Because, and one of the problems in Florida, again, the nurse practitioner needs to have this collaborative agreement with the physician, the doc tax. And that's why we got an F. Now, after the study came out, the nurses in Washington State said, we got on like a 95, so we want to address those issues. So we pointed out to them exactly why they got a 95 and not 100. They went to their legislator. They got it fixed. So now they moved up to an A+. Right? Florida, nurse practitioners have been going to the legislator every year, but that is such a political quagmire. And even trying to get the Baker Act passed, it didn't make much did not move forward. Loretta Ford, the founder of Nurse Practitioners, says instead of nurse practitioners going with one thing at a time, like get the Baker Act approved. There's another thing about signing death certificates. Rather than going for each little thing, open up the Nurse Practice Act, make some changes, update our regulations, bring Florida up until the 21st century. People have been hesitant to open up the Nurse Practice Act, but watch for that. That will be coming soon. Here's what the map looked like when we did the grades by states. In the red are the A's, and the fuchsia, pretty much the solid South. And I actually looked at interesting. I looked at this and I compared this map with passage of the ERA, Equal Rights Act for Women, and it actually correlated really well. So there are issues about nurses being a female-dominated profession and how they're perceived and how much political clout they have, or how the regulations are mapped out. Now Massachusetts, which is up there in the New England, which some people would think is the radical left-wing states, they didn't do as well. I don't know whether they got a D. I think they got a D. That's a very physician-dominated state. That's where you've got Harvard, Tufts. I mean, you've got a whole slew of medical schools. All right. So the future of nursing, the IOM Institute of Medicine report, basically has 4 pillars that they recommend. Enable nurses to practice to the full extent of their training by removing those scope of practice barriers. Have nurse practitioner residency programs. Increase the proportion of nurses with a bachelor's degree to 80%, right? And double the number of nurses with a doctorate. This is within the next 7 years. All right. Prepare and enable nurses to lead change. And the last one is improving workforce data and collection analysis, because we really don't. There's no really solid numbers on the solid data on the numbers of nurses in practice, nurses with different degrees. Florida has the Florida Center for Nursing, which compiles a lot of that data, but it's imperfect. Now, Florida has a Florida Action Coalition, which is staffed from the Florida Center for Nursing, which is working on implementing the Institute of Medicine recommendations here in Florida, and focused on those same 4 areas. And here's some, the website for the future of nursing, for the campaign to champion nursing, and the Florida campaign. But let's open it up for questions or comments.
Thank you very much. My question is, with the influx of the new patient population coming into play in the next couple of years, do you think that the passage of some new regulation in Florida for the NPs will be lax, a little bit more, not lax, I shouldn't say that, but will improve so that the responsibilities will be given more to the nurse practitioner?
You're asking me to predict what will happen in Florida legislature?
What's your common sense answer
Something
to that?
has to change. Something has to change, and not just the regulations of nurse practitioners and nurses, but also education, funding for education. We have a lot of work to do in the state. Now, one thing I didn't mention is there is this document where all the nursing organizations developed a model act of what a nurse practice act should look like in every state. And you can compare your state to that, and Florida gets an F on that study as well. Because we really haven't opened up that practice act in many years. Will all the forces that are coming together with this transformational change in healthcare bring about that change? But in 1792, there's a fortune teller. And it might be good to go and ask her, because she probably is just as good at it.
It's actually to do with the legislature again. So the Nurse Practice Act does this group have an advocacy body where it's written, and in March we're going to see it on the floor? How far along are you in
Well,
the
there are
process?
several nurse practitioner organizations and nursing organizations, and there's a coalition of nurse practitioners as well, which is a coalition of the organizations. But what's different now for the Campaign to Champion Nursing and the Florida Action Coalition is it's not just nurses. It's AARP, Blue Cross Blue Shield has been a major force behind it, right? Because for purchasers, this is an issue that makes a difference of having the services, having the networks. So it's getting there, getting a lot of people to agree. It's like herding cats. This whole debate about whether we should open up the Practice Act or not. There are people who've been working on policy issues for a while who just shudder at the thought. But if we don't open up the Practice Act and revise it and we just tinker with it, it's going to be very small change that will not meet the need of the public.
I have a great sense of humor. I hear you proposing that we go with a national program. You even said, the one woman said that, forget Florida, we should be doing this on a national basis. And I think about the Department of Education, one of my personal favorite departments, where we just had to have a national education program. But I can't find anyone who can tell me what those people do with the millions, maybe billions of the Department of Energy. Jimmy Carter said we had to have one, and we got one. And so I personally don't have a lot of faith in the federal government. I think we're going to see that real soon on October 1st, where we had to read it to know what was in it. And that's my big concern, because I like my doctor. I like my nurses. Okay, I want my doctor to make money. I don't want him to be a poor guy. I want him to have the money so that he has the education and the knowledge. I want those nurses to have the same thing. And so a national program, I got huge concerns about that whole idea.
Let me clarify, because apart from the issues of national programs, it's having a national set of regulations of what is a nurse practitioner, national standards, which is different. Because why should what a nurse practitioner is differ from state to state to state? We have for nursing, and partly from the nursing shortage, compacts with several states that if you're licensed in one state, you can practice in another state. You can have reciprocity, right? But the human bodies in Florida, they're bigger than the bodies in Colorado. But other than that, they're really still the same overall health issues. Why should we have such a, when you go back to that map, why should we have such a patchwork system of regulations of what's a nurse practitioner? Not necessarily a program, just a national standard of regulations. Now, this becomes an issue because a lot of employers of nurse practitioners are national organizations. The Minute Clinics, Take Care, United Healthcare, federal government, the VA. They are saying we really need one set of regulations. We can't set up and operate our business with the nurse practitioners that in one state can do this and another state can do this, but this has to happen. It's been a real barrier. So,
I just wanted to ask, on one of your slides, it said by 2018, 22% increase in nursing positions. Is that in at a hospital level, the increase? Or
that's overall.
So
now,
we're looking, because
right.
My concern is, the offices where they may not pay the nurses as well, and therefore, the doctors are in a real bind to find good medical care as well for their patients.
I think the nursing shortage, and there's even though offices don't pay as well as hospitals, there's a lot of advantages to working in an office versus the hospital, right? The least of which is shift work, but in 12 hours. Right. So
and as consumers, we enjoy having the employees that are there and they stay, and so I'm just wondering where that increase.
Well, and I think the issue is the nursing shortage hit hospitals worse because for various reasons. But it really will permeate everything if we don't have enough nurses. If the profession is not attractive enough to bring the brightest. We did have, for a long time, the brightest women went into nursing, like in my generation, when we didn't want to go into become doctors, because then no one would, we were told no one would marry you if you get that much education, right? That was really common. right? So then all these women went into medical medicine instead of nursing. But now things are shifting again, and that nursing profession has such potential for really helping solve the issues. Now, a lot of offices, and let me ask you, do you think the offices that had gone to using medical assistants and not having nurses, now with accountable care, will they be bringing nurses back in to do that patient education and guidance? And you had a response to my question, I think.
Yeah, I think that's the problem right now because a lot of doctors' offices they're using MAs, but unfortunately, the patient that's coming in assume that the MA are nurses, you know, and that's a major problem because the quality of care will be different. The MA is not trained to do disease care management to recognize certain, when they triage the patient for them to say, okay, there's a problem right here, and that's a concern. And just to respond, I'm so sorry, just to respond to what the gentleman said about standards, in terms of the medical field, I'm currently going for my nurse practitioner. The standards will truly be beneficial for us as nurse practitioners because then it's gonna across the board will set a standard to how we practice and that it will improve quality of care because I think the basic of things is just trying to improve the quality of care across the board that we know what our function is. One thing that you mentioned during your lecture, you're saying that the nurse practitioner actually now cannot practice independently. Is that what you're
You
saying?
have to have a collaborative agreement.
Okay. So in the case of those minute clinics, aren't there nurse practitioners in those minute
They
clinics?
are, and there's a there's a physician in the system
In the
that's
system that they have to.
overseeing their care.
Oh, okay. Because all right. Okay. Thank you.
That pretty
Let's
much
take it.
covered what I was going to comment, but there are practices out there right now currently that the doctor is never in, that the nurse practitioner or physician assistant is the one that sees the patients, prescribes medicines, and the only time the doctor gets involved is if that patient becomes so ill they become hospitalized and the doctor's all of a sudden there. I know this from personal experience. So I guess, would you comment about the dangers of having the nurses be in total control of the patient and seeing the patient without the doctor's supervision? Although the office says the doctor is looking over and supervising, there's no way that this doctor is reviewing every file that goes through his office and seeing what's being prescribed to the patients by his assistants. Could you comment about that?
Okay. No, I think there is a legal liability because the way it's set up that I think puts physicians in an untenable situation. They're not there, but they're tied into the liability. Now in Florida, physicians don't have to have malpractice, but nurse practitioners do, which is a really funny lawsuit issue. But if the physician is not overseeing care, you're paying extra for him to take his cut of your visit fee, and that's part of what raises the cost of providing care. And if in the states where there's not this physician oversight, again, outcomes are the same. So now a lot of times the physician doesn't get involved when the patient's sick enough to go to the hospital. A hospitalist takes over. So there's not even that involvement. And that's part of what we're trying to address is let's make care efficient. 90% of what gets seen in a primary care office is relatively simple. It's helping people manage diabetes, hypertension. It's much more about education, understanding the patient, guiding the patient to make the changes, to eat well, lose weight, take the medicine. That's really the essence of a lot of, especially adult care, and pediatrics is similar. The important part is a good nurse practitioner knows when it's beyond her scope of skill and to refer out. A good primary care doctor should know when to refer out as well.
Thank you for coming and providing us with all this information. Very useful. But a question, and I think it's in line with what some other comments have been, is I think as a consumer, we have a blurred vision. We don't understand who is really treating us, whether we're in a hospital setting, a nursing home setting, or in a physician's office. And I think part of the education could be defining who we are as practitioners and knowing what kind of level of care we're actually getting.
Good point. There is a document from the campaign that outlines the different levels, because people get confused when I say I'm a nurse practitioner. They say, oh, you're a licensed practical nurse, which is very different. So we have a lot of education to do. But also, and we have to move beyond, if you're female, you must be a nurse. If you're male, you must be the doctor. That's got to go.
Mine kind of falls under the public perception. I've got 4 friends that are nurses, 3 are guys, and 1 is a female. The female has her master's. And I guess the idea, when you're talking about the care, if you flip the light switch today that allowed nurses to have the exact authority that doctors have, there's still a public perception of who you want taking care of you. And I guess with me, I look at it and I say, if it's a board-certified doctor, I know there's 4 years of college, 4 years of med school, there's an internship. So there's all this stuff that says they're not fly-by-night, this is what they've committed to. Then I see a commercial for a local online school where you can get a nursing degree in whatever. So there's a public perception that with the friend that has a master's, I'm like, sign me up. I will do anything she says. I'll trust my life to her. But then some of my other friends, I know them, and I don't know if they want to make a career out of it. I don't know. And so I guess you'll still have to combat some of that from the consumer level's perception. And do you know of anything?
Well, one thing is we call nurse practitioners advanced practice nurses, and that is an advanced practice beyond the basic nursing. But if you had friends who were physicians, you'd have the same doubts. And those of you who work in the practice, some of those docs you don't want to go to, right? Come on, you admit it.
Speak to the gap. Is there that big a gap that you see out there, Nancy?
Well, I think in every profession there's a gap between what you learn in school and being prepared, and healthcare is changing so fast. And your practice might be, and you're talking about overseeing what the messages that the MAs get. Well, part of what nurse practitioners are saying is, let me be responsible for my care and take full accountability. When I see a patient who needs seizure medication to be filled and someone else's name goes in that script, I want to be responsible for that medication that the patient needs, not someone who just comes in and signs. So your practice might be unique. In fact, I think your practice is unique. The big part of the campaign is to have all practitioners operate at the top of their license, at the top of their ability, because we don't have any room for slack.
Dr. Rudner, nurse practitioners need to do continuing education after they get situated.
Continuing education, there's a certification exam. The certification exam is national. The continuing education requirements vary state by state, but they're still there.
Well, at the risk of not having everybody be able to ask a question, our session has closed for the day. I thank you, Dr. Rudner, for your presentation. Let's give it up for a nice thank you. Certainly, you can catch up with Dr. Rudner before she leaves today if you have other questions, and you can also post those questions on our LinkedIn website. Also, of course, the video will be available for everybody to be able to see online as well. Thanks for coming out.